presented by Dr. David Nash, Dean of the Jefferson School of Population Health in Philadelphia. Dr. Nash is joined by Dr. Richard Hodak, Chief Medical Officer, and Karen Handmaker, Vice President of Population Health Strategies at Vital. Dr. Hodak will introduce Dr. Nash, and Karen Handmaker will direct questions at the end of the presentation. Before we begin, I would like to review just a few housekeeping items. First, you can use your control panel on the right-hand side of your screen to minimize and expand the panel just by clicking on the arrow in the upper left-hand corner. Second, you can submit questions using the question panel located near the bottom of the control panel. We will take this time to answer as many questions as we can during the Q&A portion of the presentation. If your question wasn't answered, we will respond to you individually after the event. And finally, at the end of the webcast, please know that we would like for you to complete just a short survey. As always, we appreciate your feedback, and we will send out a copy of the presentation and a link to the recording within 24 hours after the webcast. Please be sure to check your emails for the follow-up information. At this time, I would like to turn it over to Dr. Richard Hodak, who will introduce Dr. Nash. Dr. Hodak, you may begin the webcast.
All right, thank you, Renee. I'm pleased to introduce Dr. David Nash today, who is the founding dean of Jefferson School of Population Health, and where he is the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy. He is board certified as an internist, and he is internationally recognized for his work in outcomes management, medical staff development, and quality of care improvement. He has authored more than 100 articles in major journals, edited 22 books, and is editor-in-chief of 4 major national journals. These publications are being used for graduate programs in medicine, health administration, and public health throughout the country. For 20 years, he has led the 3 Faces of Quality program. It is the most widely attended course on quality and safety under the auspices of the American Association of Physician Leadership, formerly the American College of Physicians in the United States. I'd like to remind you, Dr. Nash, that I was one of your first students taking that course, 3 Faces of Quality, maybe 18 years ago, and its sequel, Advanced Quality. And I still had the binders of papers used for those courses. It was about 30 pounds each. Very impressive work. I also want to say that over the past few months, several of us at Vital have been working closely with Dr. Nash on 2 notable projects. The first of these is Vital just published a book on provider-led population health management. I and others at Vital authored the book, and Dr. Nash kindly provided us with a very compelling foreword for the book. Thank you very much.
Thank you.
The second is that Dr. Nash and his team at Jefferson School of Public Health and Vital worked together to help deliver a 2-day population health symposium last week in Philadelphia for health system members of VHA's Eastern region. This was one of 3 sessions to provide VHA membership with leading-edge education on population health, and I heard it was really a great success. With that introduction, I'll turn it over to you, Dr. Nash, to begin.
Great. Well, thanks so much, Richard, and hi, everybody. Thanks for taking time out of your busy schedules, and I hope it's warmer where you are than it is here in Philadelphia. And finally, thanks to all my colleagues at Vital for their real amazing integrity, professionalism, and competence in this area, too. Well, let me tell you what I'd like to try to accomplish in our precious limited time together. The title of my webinar is Population Health, Creating a Culture of Wellness. For those of us in the hospital world, right away, that's a problem, creating a culture of wellness, because you and I, at least historically, have been in the sick care business, not the well care business. So what I'd like to do is try to divide my comments roughly into 4 parts. Part 1, a little bit of review of how did we get in the jam we're currently in, and a little bit of detail about the current problems facing our healthcare system. Part 2, I'd like to define population health, at least the way we interpret it here in our School of Population Health. 3, I'd like to give a quick overview of the accountable care issues within the Affordable Care Act, and then finally look into my cloudy crystal ball and talk about the future. So part 1, the jam. Part 2, population health. Part 3, health reform. And part 4, what does all this mean? Next slide. So for colleagues who are on the phone with us from around the country, I'm so proud to be coming up on year number 25 at Thomas Jefferson University. I want to remind our colleagues in Virginia that our school is in Philadelphia and not in Virginia. This is the floor of our gymnasium where our undefeated basketball team plays. And of course, we don't have a basketball team or a football team or any undergraduates for that matter. So Thomas Jefferson University, our new tagline as a health sciences university is Jefferson Health is all we do. And I'm incredibly proud to lead the smallest, newest school on our campus, the School of Population Health. More about that later. Next slide. So whatever your politics, I hope you enjoy this cover story from now a number of years ago, the British news magazine, The Economist. And of course, it's President Obama dressed up as a doctor. I can't tell whether he's a surgeon, anesthesiologist. One thing is for sure, that is a big syringe he's holding, and the pain level, most of us have not felt that pain level yet. So we're going to be talking about some pain coming our way, especially in the first part of our time together. Next slide. So here I think is a great picture, and I want to give attribution to the CEO of Bay Care in Tampa, Florida, from whom I stole this slide. So here's this hapless physician in scrubs perilously balancing between these two canoes. And the canoe with the red backpack, of course, is where we currently are. The more we do, the better. The more tests, the more labs, the more procedures, the more admissions, the growth, everything is focused on more is better. And if this hapless doctor jumps into that canoe, he'll be okay for another 100 yards or so. But what he doesn't know is that about 1,000 yards downstream is a gigantic waterfall, and he's probably not going to survive. A second choice, I guess, is he could jump into the drink and call it a day. And I'm getting pretty old, and many of my clinical colleagues in my age bracket, they're just feeling that maybe it's just not worth it, time to retire, jump in the drink. But I think the real choice today that we're focused on, of course, is getting in that other canoe labeled value-based payment and population health management, which is, of course, the theme of our time together. So my view is we don't really have a choice. We can adapt, and that is jump in the canoe of value-based payment. We can try to just, migrate and move away, or we could jump into the water, and that's the end. Next slide. So again, in part 1, one of the things I want to concentrate on is some of the challenges that are sort of inherent in our system. And I love this teaching slide that we use virtually every semester in our School of Population Health. So you could read this cover magazine story now. It's almost a decade old, still true today. So in Business Week magazine, now called Bloomberg Business, you got this doctor on a roulette wheel, kind of an obnoxious cover. And it says, medical guesswork from heart surgery to prostate care, you and I don't know what really works. And in our heart of hearts, as a poor primary care general internist, in our heart of hearts, I think my clinical colleagues would agree that at least a third of the time, possibly more than that, this is accurate. And if you believe the lifetime's worth of work from giants like David Eddy, Paul Batalden, and others, you appreciate that about 20% of what we do is based on grade A randomized controlled trial evidence. So from an evidentiary basis, we have solid stuff about 1 out of 5 times. The other 4 out of 5 times, well, that's the art of medicine. And that art is highly variable, very expensive, and of course, regrettably, prone to error. And we'll talk more about error in a little bit. But the main message here is, in our country, unlike anywhere else in the entire world, our healthcare coverage is based for most of the working population on where we work. And 50+ cents of every dollar spent on healthcare comes from our source of employment. So the people who read Business Week are employers, and they are wondering, what are we getting for the money, the vast amount of money we're spending on health care? Well, this ought to trouble every clinician on the phone. Next slide. Another thing that I find very troubling, and I hope you're familiar with this incredible report, now going back to January of 2013. So from the Institute of Medicine, pretty reliable source, it says shorter lives, poorer health. So this report, when it first came out, didn't make much noise, but only subsequently has it really engendered a lot of attention. The U.S. spending 19% of our GDP on health care. Despite that, we rank number 17 in the world with regard to the thriving, resilience, well-being, morbidity, and mortality of our population. And surely it's a complex picture of social determinants and other factors, which we will describe in part 2. But wow, number 17, really? Despite spending 19% of the biggest economic engine in the world? Let me remind everybody, given the turbulent world we live in, the U.S. spends on its military worldwide 5% of the GDP. Our industry is 4 times that size. And for that investment, we ought to do a lot better than number 17. Next slide. So just to make this as timely as possible, I hope all my clinical colleagues have read this most recent issue of JAMA that came out not even a week or so ago. An entire issue devoted to price, cost, and competition in healthcare, the annual issue. It's just an incredible treasure trove of aggravating information about what we're spending, what we're getting, medical error. I mean, I cannot do it justice in the short period of time we have together, but I sure hope you will read the whole issue because it is a troubling summary of the jam that we are in. Next slide. So the history of this jam has sort of some key milestone dates. Among them is 1999, 15 years ago, hard to believe, with the publication of the landmark watershed altering book To Err is Human, and of course in the summer of 14, when this book was reevaluated by colleagues like Peter Pronovost, Robert Wachter, and others, we know now that medical error is the 4th leading cause of death in our country in the 21st century. Impossible to get our arms around. But from 1999 to 2014, 15 years, what sort of progress have we made? It's an important self-evaluative question. This book enabled us to have this public conversation, something about which most doctors, nurses, and pharmacists knew all along, that the hospital is a damn dangerous place. Next slide. So if you don't believe To Err is Human, that's okay. Perhaps the front page and second section of the Wall Street Journal almost 2 years ago, featuring Marty McRae's great book, How to Stop Hospitals from Killing Us, based on the book Unaccountable Care. I mean, this gets everybody's attention. And again, the numbers have been thoroughly reworked. So I think by now most people understand that we have a lot of room for improvement. Next slide. Following on the heels of To Err is Human, of course, 2001, 13 years ago this past September, the publication of the watershed event Crossing the Quality Chasm, which essentially laid out a description of a new healthcare system for the 21st century. And the description of the system really is best characterized by 6 key dimensions or domains. Next slide. So the IOM back in 2001 said, listen, we're not going to tell you how to get there, but when you get there, your system ought to have these 6 characteristics. You could read them along with me. Of course, we've got to be safe. We have to be effective based on the best available evidence, use the tests that are appropriate. We have to be patient-centered, and much more on this in a little bit. We ought to be timely to reduce waiting time and reduce delays. It ought to be equitable so it doesn't vary from gender or ethnic or zip code. And certainly it ought to be efficient, which means let's do it right the first time every time. So it's a tall order to implement these so-called 6 domains or dimensions of care for the future. And what I think, and I hope will convince you of, is that population health, practicing population-based medicine, may in fact get us along the road toward implementing these 6 dimensions. Next slide. So part 2, time to kind of ask the question, what the heck is population health? It's one of those terms we use now all the time, kind of like integrated delivery system. But what does it really mean? So what I'm going to do is give you a little bit of academic background on this definition. Then I'm going to show 2 pictures that I hope will reinforce the definition. So let's go to the next slide. So this is largely the work of Dr. David Kindig and others. Kindig, still alive, of course, working at the University of Wisconsin in Madison at their Institute for Population Health. And by the way, there are now several institutes and medical school departments of Pop Health, but there's still only one school, at least for now, here at Jefferson. So back to the slide. This is the conceptual framework for population health, and it has, according to Kindig, sort of 3 pillars, 3 connected concepts. So the first is that there are these health outcomes, and they're distributed within a population, familiar to everybody on the phone: morbidity, mortality, quality of life. The second component says that there are these determinants that influence the distribution. And of course, medical care, thankfully, is one of the determinants, but socioeconomic status and genetics, choosing your parents wisely, that's a big part of morbidity, mortality, and quality of life. And then the third tier says that these policies and interventions, like the Affordable Care Act, also influence the outcome. So it's an explicit recognition here, that the social determinants of health play a very prominent role. And we'll come back to that in a minute. So here's a key question. Given the outcomes, the determinants, and the interventions, what percentage of a society's well-being is due to what you and I do every day? In other words, is due to the delivery system itself. Next slide. So here's the promised picture, and I'll let you get that slide up. So a little bit of a complex picture, but it's got the health role on your left and the health care delivery system role on your right. And it's just basically a representation of that Kindig definition, and where we want to end up is a world of well-being, thriving, and resilience for sure, and the high quality of life, ability to do our job, and so on. So once again, the question, what percentage of that thriving, well-being, and resilience is due to that little box on the right, medical care? And the answer, somewhat counterintuitively for a lot of colleagues, is, well, about 15 to 20% of a society's well-being, thriving, and resilience is due to the direct provision of healthcare services. Next slide. So another way to look at this, with wonderful data from several reputable organizations around the country, on the left, what makes us healthy? You know, this is, after all, a webinar on creating a culture of wellness. So what makes us healthy? Well, a big chunk of that, of course, 50% is our own behavior. You know, I won't ask you what you had for breakfast this morning or whether you got up early to exercise. The environment, big part of it. Choosing your parents is still about 20% of the story. Oh, and access to medical care, according to these organizations, not 20%, not 15%, 10%. And on your right, this is how we spend our money, the vast majority on the delivery of the services themselves, and behaviors and others contributing a small amount to where we currently spend our money. Well, we have to reconcile this. So summary statement. We're in a jam, colleagues, in a world of unbelievable healthcare spending. 19% of the GDP gets us to number 17 in the world. We have a complex, heterogeneous, very large country. All of that is true. But what's also true is, from the people who pay the bills for what we do, we're in a jam. We're not getting the value for the money we're spending. Next slide. So let's think about these issues from a more academic perspective. So here in our school, we have a wonderful paperback textbook. I love the subtitle here, Creating a Culture of Wellness. When our book came out now almost 4 years ago now, our hospital was not too happy with the title of this book, quite frankly, Creating a Culture of Wellness. They were worried that this was really not aligned with the mission. And I would say at that time they were probably right. And that the delivery system mission, at least for most provider groups, still is not about the wellness. It's all about episodic care of the acute and chronically ill. Next slide. Well, I'm grateful for the opportunity to be the editor-in-chief for the last decade of Population Health Management. We've called it Population Health Management for 10 years. Of course, this is the scholarly peer-reviewed journal of the Population Health Alliance in Washington, D.C., and our school is the editorial home for this wonderful journal. So if you're interested in population-based programs that are working and not working and why not, I sure hope you're a regular subscriber and reader. You know, one journal is not going to change the world, but I'm confident that Population Health Management is a great resource for where we believe this entire field is going and what the social determinants are, the influence of the environment, the delivery system. Is your diabetes screening program working? Is your colon cancer prevention program worth the squeeze? You get the idea. So I hope you're a regular reader. Next slide. So I think conceptually, among the challenges we have in population health here in Part 2 is, can we take Don Berwick's notion of the triple aim, right? So improving the health of the population, improving the experience of care at the individual level, and reducing per capita costs. Can we do all three things? Boy, I hope so. I'm pretty confident we can improve the individual experience of care. I'm really hoping we can reduce per capita costs by following protocols and practicing evidence-based medicine. And boy, oh boy, improving the health of the population. Well, that's going to have a big, big behavioral component, nutrition, behavior, counseling, income disparity, all of the challenges that our society faces. And a big part of that, of course, is our own personal behavior. Next slide. So among the challenges we have, next slide, I think among the challenges is this one. And I hope you're enjoying this, a picture of Michelangelo's David. This is the November 19, 2014 version of Michelangelo's famous sculpture in Florence, Italy from the Renaissance. If he were to be done today, this is what he would look like. Next slide. So the challenge is, yep, he's back. And let's see if we could delve a little deeper into what caused all this. So what percentage of adult Americans do all 5 of these things currently? Very quickly, exercise 20 minutes 3 times a week, don't smoke cigarettes or cigars, eat their fruits and vegetables regularly, wear a seatbelt, and are at an appropriate body mass index. And I know the reference there says 06. We have subsequently rechecked all of this with the authors. So you might be very depressed to learn, colleagues, that 3% of American adults over 18 do all 5 of these things on a regular basis. Now, that's a real behavioral challenge that our nation faces. I like to summarize this sort of tongue-in-cheek. You know, our country's culture is, let's take our simvastatin on the way to McDonald's. I'm happy to pay for the Big Mac myself, but maybe you'll pay for the simvastatin. That's kind of the way our whole system is organized. So this behavioral piece is gigantic. There's no denying it, and we're going to have to find clever, important, evidence-based, cost-effective ways to influence patient behavior moving forward. More on that in Part 4. Next slide. So today, if I made rounds at your hospital, and certainly if I made rounds at Jefferson this afternoon, we'd know that smoking, an unhealthy diet, physical inactivity, and alcohol, together, this is still 40% of all deaths in our country. I mean, staggering, staggering. So if we could tackle cigarettes and obesity and physical inactivity and, of course, the ancient scourge of alcohol, we could probably have a huge impact on the health of the population. Next slide. So the challenge then, remember those Kindig 3 tiers, that third tier about policy, well, we're in a policy jam. So right here in Philadelphia, we've got 3 NCI-designated National Cancer Fully Comprehensive Centers. We have 3 cardiac transplant centers in a city where 25% of the population still smokes, 25% of the population is in poverty, and half of that 25 is in what Uncle Sam calls deep poverty. So, wow, we're going to have to find a way to sort of resort the deck here to tackle this. And number 2, chronic disease, which drives most cost, 80% of the disease burden, really has no dedicated federal funding stream. Good Lord. Next slide. So this is the bridge to part 3. So part 1, the jam we're in. Part 2, what's population health? Now part 3, I love Malcolm Gladwell's first book, The Tipping Point. So here's the question. Have we reached the tipping point? Are you really ready to reduce subspecialist income? Are you ready to close hospital beds? Are you ready to engage with the community? I mean, these are difficult questions. I don't know the answer in your neighborhood, but clearly some pretty tough questions. And are we then at the tipping point where we all agree universal access, reducing morbidity, mortality, getting us to a higher level of thriving and resilience? Next slide. So I think this is all of health reform in kind of one slide with 4 boxes. Let me go through these cost containment strategies very quickly because we're really today focused on accountability, kind of the most important box. So the first box says we could tie payment to evidence and outcome. Well, okay, sounds easy. What's the evidence and where do we get it? And can it be done in a timely way? And can we really influence behavior by realigning the economic incentives? All of the research evidence would say, yes, we can, but it's going to be a battle at the front lines. Second box, reimbursement for the coordination of care. Well, hospitals certainly are not too good at coordinating care once patients leave their 4 walls. We know that, certainly in our delivery system and everyone I've ever visited, because care coordination has not been our core strength. Number 3, that bundled payment for both doctor and hospital services, and we can divide that up either by episode, the specific admission, or by the condition over, let's say, a year. So a bundled payment says, hey, it's not just about that primary care doctor gatekeeper. It's about that primary care doctor and who she sends her patients to, which subspecialists are in the network. More about that later, too. So the bundled payment, it's really kind of capitation in a broader sense, that we're going to give the system a set amount of money for certain disease conditions. And Uncle Sam's not going to tell that system how to practice medicine, but that system will have to figure out about how to practice in the most efficient way possible. And then finally, accountability for results. Well, I think an accountable care organization is a nice way to frame it. That may not be the only way. What I'm all about is transparency and accountability for all outcomes moving forward into the future. So next slide. This picture sort of describes the range of models with starting in our yellow, the current state where we make some modest money in PQRS, and then we're in a pay-for-performance program, and then we're in a bundled payment program. Oh, and then we might have a special chronic care or disease management carve-out, and then eventually we mature up to the point where we're in an accountable organization, whether we're a Medicare patient or a commercial patient, and that organization is focused on measurement, closure of the feedback loop, practicing based on the evidence, and if you would, in one word, trying to achieve value. Next slide. Well, my FITEL colleagues did not make me put this slide in there. I've been enamored of this for really the last 2 years. I just love this screenshot that says Population Benchmark Report. This is where we've got to go. And my dream as a primary care general internist is to one day turn on my laptop in the office and have this screen pop up. Because only this way with a registry type function am I going to know how I'm doing. And will I be able to practice what I have come to call a new type of medicine, population-based care? And the goal here would be, how are my patients who have diabetes doing against the best care possible for patients with diabetes in my region? And where do I fall short? What are the gaps in care? How do I address those gaps, that quality chasm? How do I improve? And I've got to have good data, good information technology to drive my clinical decision-making. Next slide. Our school participated in a national Mckesson survey, which was published just a year ago in Health Leaders Intelligence. A wonderful piece. I hope you'll go and look at it. And this report, just exactly a year ago, was all about, wow, population health is not just a new name, a new flavor. It's all about reorganizing the delivery system to practice a different type of medicine, using protocols and registries to drive change. Next slide. So with our colleagues writing in Health Affairs, I just thought this was wonderful, this piece by DeVore and colleagues, driving population health through an accountable care organization. That's really what we're talking about. So we want to take those patients, those chronically ill individuals, we want to stratify them, we want to put a lot of resources into the chronically ill, we want to coordinate that care. We want to keep people who are already healthy. There's a whole list of things that we need to be doing to practice population-based care. Next slide. So here's my list. I'm sure you could come up with a better one. We don't have any ownership over this, but at least it's a way to organize the conversation. So we've called this the Lucky Seven. So let me quickly go through each of them in turn, and then we're going to turn to part 4, the final part of our time together. So the Lucky Seven here at our school is all about, number 1, well, how are you keeping your own patients, or your own employees better, your own employees healthy? As a great example, Thomas Jefferson University has about 7,000 full-time employees. We're just beginning our journey on keeping our own workers healthy. We're just beginning that journey now. We ought to have been doing this for a decade. Number 2, the lifetime's work of Dr. D. Eddington and others. If he were here, he would say, well, David, don't forget, keep the people who are well, and make sure they stay skinny, they take their meds, they exercise, they don't smoke, because if they become recidivists, we're all in a jam. So you've got to keep the well. Number 3, those patient-centered medical homes we talked about back on the 4 boxes. Well, who's going to lead those patient-centered medical homes? Doctors? I hope so. But just because you have MD after your name doesn't make you, de facto, a leader. You're going to need additional training, additional expertise. Where is that going to come from? Number 4, the registries. I showed you a great Vitel example. We're going to need all kinds of tools using information technology to assess the size and scope of the quality chasm. Number 5, those funky retail clinics that many of us thumbed our noses at a number of years ago, like Take Care and Minute Clinic and so on, from Walgreens, CVS, and all the others. Well, I'm sure you appreciate that here in Philadelphia on our campus, an insulin-dependent diabetic sees her faculty endocrinologist twice a year. That same patient is in her corner Walgreens 32 times per year. So where are we going to deliver care? And where are we going to educate this patient? Probably inside the retail clinic. Number 6, our managed care partners. I'm a big proponent of organizations, large and small, working with managed care partners who know all about managing risk, have scores of actuaries helping them. Number 6, how many actuaries does your integrated delivery system employ? And then finally, what this program, this wonderful webinar, and my time with you today is all about, leadership training. None of this is going to work without nurse leaders, pharmacy leaders, doctor leaders. We can't do it without good leadership. Next slide. Well, here's the president of your medical staff, or here's the leader of your multi-specialty group practice, and I'm sure they're wonderful people, but they are like a deer in the headlights right now wondering, what is all this stuff and how can I get my arms around it? So let's start the fourth and final part of our time together. Next slide. So what does all this mean? Well, I think it means a couple of things. Number one, transparency. If you're worried about transparency, well, then you better be worried. I believe we ought to have our success rates, our error rates, our patient satisfaction scores, everything online 24/7. The only way to establish true accountability, which is a cornerstone of professionalism, is all about transparency. And as some of you, I hope, know, our school coined this 4-word phrase, no outcome, no income. If we don't find a way to get a good outcome, we're not going to make the kind of margins that we need to grow and to improve the care of our patients. So no outcome, no income, I think is a pretty pithy 4-word summary of where we are in our journey since the passage of health reform. Next slide. So how do we get there? Well, let's summarize. We've been talking a lot in the last 35 minutes. So number one, we've got to practice based on the evidence where we can find it. Number two, we've got to reduce unexplained clinical variation. There can't be 14 different antibiotics for community-acquired pneumonia. There just can't. Maybe 3 or 4, not 14. Number three, we've got to reduce slavish adherence to professional autonomy. It's a fancy way of saying, hey, I know we're good, just ask us. Well, when we actually measure, we realize we could probably improve. So this adherence to we know what we're doing 24/7 has gotten us, I'm convinced, in large part to the jam we're in today. Number five, measure and close that feedback loop. If you give doctors, nurses, and pharmacists good data about how they're doing relative to a peer group, and then you teach them how to improve, my experience in the last 25 years is they will stampede to improve. But you got to give them the education, you got to close the feedback loop, got to be done in a non-punitive, non-threatening way, and then most practitioners will find a way to improve their outcomes. Finally, I think we got to engage with patients, and today's not the day, but wow, there's a whole industry out there now of patient engagement companies, a huge amount of Wall Street money going into hundreds of new firms that are all about connecting online with patients, typically through a web-enabled smartphone. Next slide. So even the Institute for Healthcare Improvement, where I stole this slide, maybe you realize just 3 weeks ago they launched yet another new program called 100 Million Healthier Lives. So I'm sure you all remember 100,000 lives to save from medical error. Now, Maureen Bisignano and her colleagues have launched this new national effort, which I applaud, creating a culture of health where 100 million lives could be improved. What a wonderful goal for our country to embrace. Okay, next slide. Well, I hope you like this funky picture. This is me occupying Wall Street. I want to leave you with just a couple of thoughts for the future. By the way, that phone does not work. The floor of the New York Stock Exchange is largely now just a financial television station. Next slide. So let's talk about the future. So I borrowed this from the privilege I have of working as a board member at the Humana Corporation, and I have permission to show you this slide, which I think basically tells the whole story. So medical management of our members, those are our Humana beneficiaries, across a continuum on their needs, but basically the message is, wow, 5% of the millions of patients that Humana manages, 5% are responsible for 41% of the total cost. So what's the goal? Well, it says right there what the goal ought to be. So we're going to do integrated medical, behavioral health, medication therapy management. Senior Bridge is our in-home service. Now all of this is called Humana at Home. Forget about the Humana piece. What's important here is a small percentage of chronically ill patients are driving a way disproportionate share of the total cost. We've got to be focused on this small group and manage and coordinate the heck out of them. Next slide. So let me conclude with 2 minutes of shameless advertising. Once again, I'm so privileged to be at the Jefferson School of Population Health. These handsome folks just are displaying some of our degree programs. Very quickly, we have 4 master's degrees, a master's in public health, fully accredited, our master's in healthcare quality, our master's in health policy, and our master's in health economics and outcomes research, not pictured here. 4 master's degrees, all of it online. So gosh, if anybody's interested in joining us for any aspect of this, I sure hope you'll reach out to me. My email is on my first slide. I would love to talk with you. Last slide, please. So John Cotter is one of my teaching heroes, of course, retired professor at Harvard Business School, an amazing author, more than 30 books on leadership. And as I've already noted, without leadership, we're not going to get anything done. And John talks about the institutionalization of leadership training is a key attribute of good leadership, which is a fancy way of saying your job as current leaders is in part to train the leaders of tomorrow. Boy, among those leaders are Dr. Hodak. I hope you're going to read his new book, Population Health Management, a provider approach, really fantastic book. And I know you're going to enjoy it. And I was privileged to be able to write the foreword to that great book. I think it's right up there with the textbook from our school, too. So let me summarize. We did 4 buckets. Bucket 1, the jam we're in. Bucket 2, a little bit about the definition of population health. Bucket 3, health reform, all about transparency and accountability. And then bucket 4, where I think the world is going and how we might get there. So once again, thank you. Let me stop there and then back to our wonderful FITEL moderators. And I'm happy to try to answer any questions that you have.
Great. Thanks, Dr. Nash. At this time, you can submit questions using the chat panel located near the bottom control panel. Actually, it's the question panel. Karen, I'm going to go ahead and turn it on over to you to manage the queue. We will just pause momentarily while questions start to populate.
Thank you, Renee. Thank you, Dr. Nash. That was excellent.
Thank you.
One of the first questions that came in ties to your slides about behavior change.
Yes.
And the question is, what have you seen as evidence-based efforts to change behavior? What are the things that are working?
Wow, it's a great question. So all around the country, I mean, there are now scores of programs on smoking cessation, weight control, depression management, heart failure management. I mean, the key here is harnessing the tools of behavioral economics and behavior change and aligning economic incentives with our patients. I have many of the major integrated delivery systems, many of the managed care plans have very successful programs in behavior change. So folks who are really interested ought to be reading the journal Population Health Management, where we regularly describe these programs from around the country. So this is no longer a secret.
Okay. There's a big question is when you talk about the transition with the folks with 1 foot in each canoe, yes. How do you keep everybody financially whole as you do that transition? What's the secret?
Okay, well, that's a great question. So the sorry answer is it ain't going to happen. We're not going to keep everybody whole, which is why organizations are joining with groups to get bigger to be able to withstand the financial crunch that's going to occur as we make this transition. People will not be made whole during the transition. I don't think that there's any nicer way for me to say it. So for subspecialists in suburban Long Island, New York, who are netting a 7-figure income, as described in the New York Times just in this past year in a series of articles, I mean, this is just unsustainable. So if we're going to continue to do that, those persons are going to have pain in the transition to a culture of wellness and prevention. There's no nice way to describe it.
Thank you. I think that is an honest answer. So here's a question for you, Dr. Hodak. Does a population focus lose the individualization of care? For example, how do you tailor care to individual patients based, when you're striving for benchmarks like A1C less than 8?
Yeah, thank you, Karen. You don't lose that individual character. It's population health, one patient at a time. You take that patient and you concentrate on a patient that has that value greater than 8. What happens with population health that I really think everybody should take a close look at is you have to be able to see the whole population. There are people who are coming into the office, and those are the people who are they're ready to be taken care of, but there are other people out in a population that you may be responsible for that have the 8 and don't know about it. So being able to have data that is showing you across the entire population is extremely important to managing a population.
I would jump on there. Richard's given a great answer. I would add, Karen, I think the registry function, that is a key piece here, and I can't emphasize that enough. And not just because we're on a FITEL-sponsored call, but any organization that can get us a registry. In other words, our patients, how are they doing relative to patients under someone else's care? That is what's going to realign the incentives clinically and economically. We've got to have that tool. It's way more than an electronic medical record. It's being able to compile those records in an easy-to-use format so that dummy clinicians like me can get online and evaluate how I am performing. That is the secret here, I think, from a technologic perspective.
Thank you. Another question, we're getting quite a few questions that I'm going to try to sort of group together here about information technology and data analytics and population health tools. Dr. Hodak, can you give us some perspective on where organizations should start, and what is the best strategy to make your technology investment for population health?
Well, I think it kind of follows on what Dr. Nash said. The registry is really the fundamental tool that is needed to be able to see all the individuals in the population and where their gaps in care are. So that is the first thing that you really need. Then you may need some help in being able to reach out to all these people, because they're not necessarily going to be coming in the front door. You need to be able to reach out in some way, and that's either going to be using a lot of phone calls by different people within the office, or being able to use tools that kind of automate and find the gaps in care that are in that registry, and that may help you get a good start. You also are going to need to be able to track how you're doing on those gaps in care. So having some way to have a framework or a dashboard that you can see, like the slide that Dr. Nash showed in his presentation. You have to be able to track and see that you're doing well. So those are the things that would be starting. But I think starting with the registry is really the most important thing.
Thank you. Another question, also tied to data analytics and expansion of care beyond the 4 walls of the hospital into the community. What do you see, Dr. Nash, as the future of HIEs and connectivity across multiple systems that today don't necessarily talk to one another? This ties to your point about the poor job hospitals do coordinating care outside their 4 walls.
Wow, what a great question, and I did not cover HIE just given the amount of time we had, but boy, I sure hope I live to see it. You know, I'm a believer that imagine here in Philadelphia where we have 5 medical schools, imagine if we could share some information about patients that go from one ER to the other or one specialist to the other. Boy, wouldn't that be wonderful? I hope I live to see it. It would be a critical component of our ability to reduce costs, reduce unnecessary utilization. I'm not very confident, though, that that's going to happen anytime soon. It may be in other marketplaces. Here in the city of brotherly love, we don't really love each other across these 5 big systems. And I just don't see how the HIE is going to operate. I hope I'm wrong, but I think to answer your question, Karen, it'll be vital in the next 3 to 5 years to be able to share that level of information. Maybe more realistically, within these merging systems, we'll have the ability to share data. Even that would be fantastic.
That ties to another question that either one of you can answer. As you look in the crystal ball, even given what you just said, Dr. Nash, people are asking from our webinar, how long is this going to take? Are we going to really see meaningful change? Is it accelerating?
Yeah, boy, what a great
velocity?
question. I sure wish I knew the right answer, because I would run out right now and buy a lottery ticket. So, you know, all kidding aside, I think there's lots of way smarter people than me who are trying to tackle the time frame issue here. And from what I can read and from the national leaders who I've spoken to, they're talking about a 3 to 5 year time horizon. And that sounds about right. I mean, when you think that 8, 9, 10% of total Medicare dollars are going to be at risk by 2020, that's not far away. So if we're going to put, you know, 8, 9, 10% of every Medicare dollar kind of in an accountable position, well, that's going to transform the marketplace. And the registry and the HIE will be a part of that transformation.
And Karen, I can probably also, you know, jump in. I just reviewed, you know, some of the data for the patient-centered medical home. That is just growing exponentially. I think the latest numbers on it, there are over 45,000 physicians that have gone ahead and created a patient-centered medical home. I think as we look at our client base, the majority of them have a patient-centered medical home. And then we've been with people with the Accountable Care organizations that have said probably in that 3 to 5 year period of time, there may be as many as 40% of the patients under the management of an ACO or some form of accountability. And a journal article early in January of this year sort of showed how many ACOs there are. That also is growing exponentially, not just with Medicare, but with commercial insurance as well. So it's coming very quickly.
I think that's all very, very encouraging. Another question, and Dr. Nash, this one really I think is for you and has an academic perspective to it. Yeah. There are some folks out there in our audience today who are really developing innovative clinical programs and pathways and ways of deploying care teams more efficiently. What ways can you recommend to our audience to share these and test them and get them rolled out?
Wow, what awesome. So I have 3 ideas right away. So certainly we'd love to see many of our colleagues on December 10, 11, 12 in Scottsdale at the Population Health Alliance meeting. That's the national meeting of the organization who sponsors our journal, the PHA. In March 23, 24, and 25, our school will have our 14th annual Population Health Colloquium here in Philadelphia. So once again, March 23, 24, and 25, I hope to have more than 700 people. We had 650 last year. And then I hope people will write us and send us articles and editorials about their work in the Population Health Management Journal. So we have 2 national meetings. We have a great journal. I mean, there are ample opportunities to network both face-to-face and, of course, online with the literally thousands of colleagues who are engaged in this work nationwide.
If I can jump out of my moderator role here for a second, I am on the editorial board of the Population Health Management Journal and have been for many years. And I really would encourage the audience to subscribe because there are state-of-the-art articles in that journal every issue. I really learn a lot by being a reviewer, and the editorial board that's listed there, it represents every aspect of the industry. So I just wanted to make that point to everybody looking to learn more and deploy their stories.
Thank you.
You're welcome. Here's a very interesting forward question. Do you think, either one of you, that eventually individual health insurance plans will be, or put it another way, health plans will be tailored to each individual rather than just one size fits all?
Wow. Well, I'll tackle it first. So sure, Oscar, private exchanges, and much more to come. I mean, we're going to have highly individualized plans, and the payment system is going to look like reserving a seat on a U.S. Airways airplane. You know, the price is going to vary up to the moment you buy it.
So, I don't have anything as colorful, but I certainly do believe, yes.
Sure, and you know, and you could have less risk, you pay more risk, you pay less. I mean, that's true in every aspect of what we do. So I think with good outcomes data, we'll be able to make that work, no question.
Okay. Here, back to a little bit of the reality instead of the future, where we are right now. What are the best approaches to shift reimbursements or to encourage specialists in primary care to collaborate more, given that right now the payment structures and levels are so divergent between those fields?
Well, let me tackle that one. I'd like to see what Richard says. Well, to me, the bundled payment has growing evidence of working. And the bundled payment, really sort of like capitation, but not capitation 1995 with just the poor primary care doctor as the gatekeeper fighting off tests and procedures. That's not what we're talking about. We're talking about a bundled payment whereby the primary care doctor sends patients to specialists who achieve a good outcome at a competitive price, because everybody's pocketbook is linked. So the research evidence that I'm familiar with says bundled payment is the way to go. So I would say to our colleagues, wherever there's an opportunity to participate in a bundled payment, I would go and learn how that works and cut my teeth on a current bundled payment. Let's remember, from the Medicare bundled payment system, there are roughly 30 million people already involved in some kind of bundled payment. So this is not a new thing, and it's going to continue to expand. And I believe that linkage is going to drive improvement, no question in my mind.
Yes, and Karen, again, just last week, I shared a slide with my team here showing exactly that. Bundled payment is on the top of the list in terms of that it's going to work, and a lot of people are getting involved in it. It's both for acute episodes of care like a fractured hip, and a lot of the initial bundled payments are around situations like that, but also coming down the road may be a bundled payment for a condition such as diabetes. There are some pilots on that right now. So bundled payments are something that seem to be very popular and working.
That's very helpful. Okay, then we have, I mean, the questions keep pouring in, I have to say, but as I scan them, there are quite a few about the reality of funding this transition for care teams, for the infrastructure, for all kinds of things. What are the tricks to getting that the upfront financial support to make the transition?
Yeah, I'm not sure I understand that question, Karen. Can you help me a little bit?
Yeah, I'm just trying to say is like people are struggling. Okay, I need to shift to population health. Where am I going to get the money for the infrastructure and the care teams and for the technology?
Well, so of course, no easy answer. You know, the real issue here is this is what's driving organizations to merge, to pool resources, to undergo, you know, to have the wherewithal to undergo the transition. There is no secret pot of money here. But, you know, what I would argue is if one thing to keep in the gun sights might be how can we at least break even on a Medicare hospitalization? I mean, most hospital leaders would say that's almost impossible, let alone make a margin. So I believe if we could work hard to work towards, the triple aim and reduce that per capita cost and attempt to make a margin, even on Medicare, that'll get us in the right direction. It's going to be incredibly hard to do.
I'll give you one more second, Dr. Nash, to give a positive note to the group, or Dr. Hodak, and we have to wrap up. We're at close.
Okay, I'll let Richard go first.
Okay, so thanks very much for being here, Dr. Nash, and giving the presentation. I wish we had more time to go ahead with some of these questions because they really are, very nice questions, and they need to be answered. And it shows that people are listening to the important aspects of population health.
Great. Well, I'm thrilled to be a part of this, and I'm very convinced, of course, at our School of Population Health that this is the road to redemption for the healthcare system. And as a primary care doctor, I'm looking forward to it because I know that if I care for a population, I'm going to have a greater impact.
Well, thank you all very much. Renee, did you want to do the close?
That would be great. Thank you. Again, thanks to Dr. Nash, Dr. Hodak, and Karen. We really appreciate your time today. For those of you who we weren't able to get to your questions, we will have your questions in the queue. We will follow up with you after the webinar. We really do appreciate all your time. Just as a reminder, our next executive webinar series will be on December the 16th. It'll be on communicating within the HIPAA rules, texting and emailing with patients. And that will be presented by Adam McCoy, product owner from FITEL. So please do register. You will receive that in the follow-up information with the presentation and the recording. Thanks again, everyone, for joining us today. We appreciate your time. Have a fantastic day, and happy Thanksgiving to all. Thanks.